So we'll talk today about the management of obstetric hemorrhage and for the gynae oncology perspectives. Again, I'll go through the maternal mortalities number in Saudi Arabia, which is actually decreasing year after year. So the last year, which is 2016, maternal mortality was 42. Hemorrhage is the first cause of maternal death, and it's about 30%. In US, about 17%, and it's the second most common cause of pregnancy-related death. PPH leading to hysterectomies, it's about 42 per 100,000 deliveries. That's in developed countries. So our workshop is going to be the diagnosis and etiologies of PPH. We'll talk about medical management. Also, we'll cover interventional radiology, surgical intervention, hemostatic agent, and legal and ethical implication. So the definition of PPH, it's actually inaccurate in about 30 to 50%. Most of the time underestimated. The problem is because it's diluted with amniotic fluids. The estimated blood loss in spontaneous vaginal delivery about 500 cc, C-section about 1,000, cesarean hysterectomies about 1,500 cc's. This is the consequence of blood loss hemorrhagic shock, and it's 1, 2, 3, 4, and it's about, when you reach to number 4, it's about 2,000 to 3,000. It seems in the diagram it's difficult to reach down, but it can actually, with massive hemorrhage, it's a matter of seconds to reach to 2,000 to 3 liters. The PPH, it's early or late. The most problematic one, it's the early, which can lead to high morbidity and high mortalities. So the PPH, which is the loss of normal mechanism of postpartum hemostasis due to loss of contraction of the uterus, local vasoconstriction, platelets aggregation, or clot polymerization. The etiologies, which is the T, the 4 T's, the tone, which is the common one, tissues, which is either previa or percreta or retained products, a thrombin, which is the disease can cause low platelets or coagulation problem or anticoagulant, and trauma due to either rupture uterus or macrosomia or instrumental deliveries. Risk factors, which can be recurring one or non-recurring one. And again, we have to know all these risk factors to be prepared for the PPH problem. So the initial management for PPH, always remember, because it's always happen sudden or as an emergencies. So always you have to when you have a problem with PPH, call for help. You have to assess the patient. You have to do a quick lab test. Again, it's pressure, and give it a thought, wait, and call for help when you have any sudden bleeding. Assess etiologies, go through all the histories and see what was the problem and the cause of the bleeding. Consider transfer to the OR. Hemorrhage protocols, again, because always happen middle of the night, so it's better to have a protocol that you follow. Make sure you have the facility and sequence of intervention. So in conclusion, PPH is obstetric emergencies that need increased preparedness by antepartum and intrapartum recognition of risk factors, implementation of protocols. You have to be fast in diagnosis and intervention. Any delays may lead to great blood loss, DIC, hypoxia, and morbidity, and unfortunately possible mortalities. So I'll stop now here and I'll call for help, the second presentation, which is the medical management for PPH, Professor Hanan Qadri, Associate Dean of the College of Medicine, King Abdulaziz University, and the Consultant Obstetric and Gynecology. Welcome, Dr. Hanan.